Good afternoon. I'm Dr. Liesl Bryant, and as you know, I'm one of the risk management advocates for the Trust, and we are delighted that you can join us again today for our 27th Risk Management Roundtable. As a Trust policy holder, most of you are likely familiar with our risk management consultation service, the Advocate 800 program. It's one of the many benefits our policyholders receive through the Trust. I'm one of the 8 advocates, and I'm excited to be joined by 2 of my esteemed other advocates, Dr. Julie Jacobs and Dr. Eric Harris. So that being said, we'll dive in. Welcome again, Julie and Eric, and to all of you. We're excited to have today's webinar. We're going to talk about a lot of things, but some of them focusing on, in particular, on how we challenge in difficult times, right, when things are uncertain. And so with that, Julie, I'm going to start with you with the first question. As you know, right, there's been a lot of activity at the federal and state level recently that has led to confusion and some distress related to treating specific populations, to various regulatory changes that may impact the practice of psychology. And I know we've gotten many calls over the last few weeks and months from providers that are really uncertain about how to practice and how best to manage risks in unpredictable and uncertain times. So can you speak sort of just first to what are some of the important risk management strategies that clinicians can turn to during times of increased uncertainty?
What a timely question. Yeah, I mean, I think what we want to remember is, in light of all of the changes and all of the disruption, there are still some things that the standards of care and things that we can still hang our hats on, so to speak, things that we can rely on to provide guidance. The APA ethics code, still here. It's still the umbrella under which we all operate. APA practice guidelines, they're still there as well. And so what we want to think about is, although there are a lot of moving parts in terms of regulations and statutory changes that may be going on, we still have standards of our profession that we are supposed to follow. And those are still in full effect. Now the ethics code is under revision, and so there's going to be a new version out later this year. And it's incumbent on all of us to review that and understand it. But the basic ethical tenets are still going to govern the work that we do. Ethics code section 1.02 talks about conflicts between ethics and law. And it talks about the fact that when those conflicts do arise, we're expected to clarify the nature of the conflicts. We make our commitment to the ethics code known, and we take reasonable steps to resolve whatever that conflict is, consistent with the ethics code. And so again, it really is the foundation that undergirds everything that we do. And so when in doubt, start with your ethics code. And there may be times when the ethics code does conflict with law or regulation, and you do your best to resolve that in a way it is consistent with the ethics code. Now, I think a theme of today is going to be, we don't have all the answers, and there is a lot of uncertainty. And part of the challenge here is risk management in uncertain times. We can only manage so much. We can only provide so many answers and specific answers. And so there's going to be a lot of analyzing things on a case-by-case basis, which is always the case, but I think might be even more true today. So I just want to go ahead and voice that right now. So if you hear us talking about can't say for sure what to do in this situation or that situation, that's a nature or a basic tenet of what's going on right now. And back to the ethics code, I mean, a lot of states have actually incorporated that formally into statute. So even if you're in a state that doesn't formally consider the ethics code to be law, every state requires us to practice in accordance with the generally accepted standards of the profession. And some states even help us know what that means. I live in Colorado. Colorado specifically says that the generally accepted standards include the standards of practice generally recognized by state and national associations of practitioners in the field of that person's professional discipline. And that doesn't include statements by governmental officials. That doesn't include executive orders. That includes organizations of professionals. Psychologists are the ones who dictate what psychologists do, at least in terms of finding out what the generally accepted standards are. So that's our basic foundation. We also have other standard risk management tools that are going to be the same things that we use now, that we would have used a year ago, right? Informed consent is vital right now, especially in situations where there may be new risks or new limits to confidentiality. For example, if you're practicing into a state or in a state where gender affirming care for minors might constitute child abuse, you need to add that to your informed consent. You need to talk to clients about that things that they may have been freer to talk about could have different implications now. So making sure that your informed consent is up to date and reflects the concerns and the risks that your clients and patients need to know about before they agree to have services with you or to disclose certain things to you. Documentation, it's a great risk management tool. It's also something to be very thoughtful and mindful of right now. We need to document in a way that meets the standards of care and that's appropriate and accurate. But we do also want to be thoughtful and mindful of what we're documenting and making sure that it's in service of the clients and that it meets those standards. There's going to be a lot of, again, case by case considerations on that, but it's something else to keep in mind. And consultation. We always talk about it. I think more than ever, it's really important. Consulting with another professional is going to help you understand what another reasonably prudent psychologist in your position would do. And that's key. That just goes right back to the generally accepted standards of the profession. You also just really need to know the laws in the states where you're practicing, where you are and where your patients are located. Laws are different among states, more important than ever to be aware of those. Look for reputable sources of information. There's an organization called the Center for Connected Health Policy. They have put together resources for telehealth. And so that's not going to cover everything, but that is going to cover a lot of the information that you need. We'll throw that in the chat for you. State and national associations, your state association will be great. The state association where your patient is located, reach out to them. They have advocacy arms, they have legislative arms, they track these things. They should know what's going on at the state level for you to be aware of. And look for primary information from primary sources. HHS actually has email lists that you can sign up for that will give you updates as to what's going on with HIPAA and federal regulations. I think we might be tossing that in the chat as well. So sign up for those things, know what's going on as best you can. Things change every day, so we're all going to be making the best efforts we can. And then the last thing I'll leave with, because I'm going to talk more about it in a minute, self-care, for heaven's sake. Now more than ever, take care of ourselves. And I will elaborate on that shortly.
Perfect. Thanks, Julie. You covered a lot there. Really important information. Eric, anything you want to add?
Well, I would just say also consulting is important, even if you think you know the answer. A lot of the calls we get at the trust are calls where we confirm the good judgment of the person who's calling. And in times where there's a lot of anxiety out there, it's always helpful to have somebody saying, yes, that's right. You can go forward.
Yeah. Well, especially I think you're so right, Eric, because now some of the decisions we make are going to feel hard because we're not going to have all the answers we want in order to make that decision, right? There is information missing. It's unpredictable, it's unknown. That's why we're in uncertain times. And so it's a form of self-care, I think, to consult and sort of spread that anxiety around. I think, Eric, you're the one who coined the phrase "never worry alone," and I've taken that to heart. So okay, so on that note, Eric, I'm going to turn the second question over to you. We are getting many calls from clinicians who are practicing teletherapy across state lines, both under SIPACT and sometimes under, various temporary practice laws or those kinds of things. And the majority of these clinicians understand that when practicing across state law, they have to follow the laws of the state where the patient is. But that's, of course, a pretty broad mandate to do that. So can you give us some guidance on, which laws the practitioner would need to know, and maybe also offer some resources for where they can find those laws or locate them?
Sure, I'll try. First of all, I want to say that we can't give specific legal advice. And that's even more important for you to understand as the laws are changing and the interpretation of the laws can be more political than legal. So we want to make sure that that's clear. And as Liesl said, you need to know the laws in the state where the client, if you are a SIPAC person, or even if you're practicing under the temporary practice rules in a particular state, you need to know the laws of the state that the client resides in, not the laws that you reside in. Although, interestingly, if there is a complaint, it will be to your home board, and your home board will not only apply the laws in the state that you're in, but they will apply the laws of the state where the client is in. Um, so it's, now, how do you find out what laws are important? Well, first of all, you need to find out what the limits to confidentiality are and the age of consent of clients who can independently consent to treatment, particularly if you're working in the field with minors, because different states have different rules. We have something that we put in the chat box that talks about the ages of consent for mental health services in every state that in the country. However, what I would advise from a legal perspective, from a risk management perspective, is if you are working in a state where you're not licensed, where you're working across state lines for SIPAC, that you not see independent minors, that it's dangerous not to get parental permission. It's there are situations in your own state where it's okay to do that, and the laws may allow it, but if you're working across state lines, even if you know somewhat the laws, it's just more risky not having the parents involved, particularly with some of the subjects we're going to be talking about later. You need to know certainly the laws of tears-off, or when you have to breach confidentiality in order to notify a victim or call the police. Those laws vary. We also have a list of the different state laws around tears-off. You need to know the child abuse reporting laws, and if there are adult abuse reporting laws, you need to know what those are. Those you should try to look up before you even undertake to make the call, because you need to let people know that that's something that you might have to breach. That's the only reason that you would breach confidentiality without consent of the client. Also, if you're working with adolescents, and even if you have parental permission, you may want to be able to get the parents to sign a contract. The model is that we have on our website, which basically talks about their agreeing not to ask for information or to involve you in a court case if there is a divorce or a custody issue. And that's not, as we know, as we've said before, it's not completely enforceable, but it is powerfully persuasive. The parties won't likely violate it because it makes them look like they don't have the best interest of their children at heart there. If there are other laws that you need to know about, you can look in the state. You should always look at the state website, the state licensing board website, so that you can see what they've got on there. And you may even need to get the actual statute or regulations of the state, because some of the state websites don't have very much information on them. The other thing you can do is you can always Google your specific question and put the state that you're Googling it for. And oftentimes that's what I do to find out a specific situation, a specific law. And also, of course, you can always call us. We do have a much more complete database than we're being able to provide you with some of these questions. And we will be happy to look up and give you the advice that you need in that situation. And that's it.
Great. Thank you, Eric. All good advice. Julie, any additions there?
Just the only other thing I can think of is that because I happen to be in Colorado, I know that Colorado has some specific disclosures that you're supposed to make to all of your clients. So that's kind of a little nuanced piece that might be a little bit harder to find out about, but there might be those requirements as well. And if you go to a state board website and they have a policy statement or an advisory statement on a thing, read it. They think it's important enough to have actually put it out there, and you don't see those very often. So that's another sort of, a hack. Go to the website and see if there's a section with advisory statements or policies. At least take a look at what the topics are. And if there's something that's relevant, that might be a really good source of information as well.
Julie, just for curiosity, how would you find that provision in Colorado, the disclosures in
It
Colorado?
is, you would have to actually look at the statute. There's a section of the Mental Health Practice Act that's called mandatory disclosures to clients, and it includes the list. They also used to have a sample form on the website. It was out of date last time I checked. So that also shows the dangers of assuming, but you would have at least a good argument that I downloaded this from your website yesterday.
Yeah.
At least that gives you some mitigation of the risk. You sure tried. So I think that's fair. But yeah, I mean, that's literally something that's buried in statute. And if you're not savvy at reading that kind of thing, that could be tricky. State associations also might sometimes be able to just point you, just say yes or no, there is that kind of requirement. So that might be a good resource as well.
Right. All of those are good ideas. The thing I'll add to potentially, if you just have one patient in a state, you probably wouldn't do this. But if you're practicing, if you have a handful of patients or more in a different state, good idea to start making colleague contacts there. Get involved in a state psych association so you get notices about when laws change or don't change. So, you know, if you're going to be practicing a lot in another state, you want to be sure you position yourself to get information about the statutes and about how they're interpreted there, right? And or any unique statutes, because there's lots of states that have oddities. And if you're going to practice there, ideally you want to know those uniquenesses in advance. So great points. Okay, Julie, I want to come back to you because you mentioned self-care. And, you know, I know we talk about this a lot as a critical risk management strategy and just a human need. But can you say more about, you know, how does self-care really fit into risk management? Why is it so important? And then what are some things that clinicians can actively do to practice self-care now, especially when, you know, we're all really, really busy?
Yeah, it's a great question. And, you know, self-care feels like an indulgence sometimes, but we're not necessarily talking about a weekend at a spa getaway, although if you can, yeah. But, you know, sometimes self-care isn't an indulgence. It's just a way to make sure that we're maintaining our ability to provide good services. If we're not taking care of ourselves, we will get burned out. We will have errors in our judgment. We will ultimately potentially harm our clients. And so us first is not a selfish way to think about this. It is us being able to help people by helping ourselves. Our risk management team, I mean, I think we all consider self-care to be an obligation, an ethical obligation, and it's even sort of infused in the ethics code. It talks about needing to be aware of your personal problems, and if they're going to impact your practicing, you need to take appropriate measures to do something about it. If we're not taking care of ourselves, we are impairing our own competence. Emotional competence is as important as any other type of competence. And so if we are not competent, if we are impaired, if we are not sleeping, if we are using substances, that's going to make us vulnerable, and that is going to lead to poor judgment. So we need to make sure that we are focusing on ourselves so that we can focus on other people and make good decisions. And a lot of states also recognize this. A lot of states will actually require that I report another professional if I believe that they're impaired. And that impairment can be based on substance use issues or mental health struggles. And so, you know, if the state thinks it's important enough for me to report someone because they are emotionally impaired and unable to provide services, it's clearly something that has risen to the attention. I mean, it's clearly factually true that people who are impaired are providing potentially harmful and unethical services. So it's really important for us to attend to those things. So that's the why. And I think the what, you know, it doesn't have to be fancy. I mean, simple practices, now they're not easy, but simple things like eating well, making sure you get enough sleep, getting some exercise. It doesn't mean you have to go out to the gym for an hour. I walk my dog 30 minutes every morning. It is a space that is just mine, and I'm getting some physical activity and I'm getting outside and I'm doing something that feels good. Take care of your profession or your personal relationships, you know, nurture those, nurture community, nurture connection, especially now. Get into therapy if you need to get into therapy. We all know there is certainly no shame in that. Have fun, seek creative endeavors, paint, write, sing, whatever. All of those things can be very simple and very, very powerful. And it's not just about personal self-care, it's about professional self-care. And Liesl, you alluded to this earlier, consultation is professional self-care. Don't worry alone. Like, let's worry together. Let's validate that this is a difficult situation and connect as humans and say, wow, this kind of stinks. This is hard. And just get that not only clinical consultation, but just feeling connected and not like you're practicing in isolation. We just want to try not to burn out. So, the old axiom of the air masks, put your own oxygen mask on before you put on the one for someone else. If we're not breathing, we're not going to be able to help anybody else. So it's more important now than ever. Um, and I think I'll just leave it at that.
Yeah, great points. I often think it's helpful to remember, that when we take care of ourselves, that is a form of taking care of others, truly. Eric, anything you want to add there?
Well, I'm only half joking, but I would consider getting a dog. And
Yes, an emotional support animal.
they're very helpful to make
Yes.
sure that, particularly in these days when it feels lots of times one feels lonely, even one has a good circle of friends. So I know some people can't get a dog for whatever reason, but it's something to think about. Maybe a hamster.
Borrow a dog.
Yes, borrow a dog. Pets are always happy to see you, which is a nice thing, right? That alone sometimes can help everything. All right. So Eric, last question to you before we turn over to the live questions. Again, back to sort of our theme of uncertain times, we've received a lot of calls, as you know, lately about a variety of situations where psychologists are feeling caught in conflicts between some of the new laws that have come down, and they're feeling that those laws conflict with their ethical obligations. So can you speak to what risk management strategies we can turn to when dealing with potential conflicts between our ethical duties and our legal duties? Yeah, and I'll leave it at that for you.
Well, the ethics code basically says that when you have a conflict between an ethics code provision and a law, your responsibility is to try to do as much as you can to comply with the ethics code, and also that you can't use the law as an excuse to deny people's human rights. And that's mostly what I'm going to talk about because there's a lot of things that are going on now in the political arena and even in some of the legislatures are in conflict with the basic, um, not only the ethics code, but a lot of APA statements about certain issues like gender affirming care or abortion or LGBTQ activities. Um, and so you need to be aware of that. Um, the issues now, it's also true that because these issues have become so political, it's important to be extra careful about how you are working with somebody who is in one of the areas where risk is involved. So most of the um, I can the most of the GAC type laws don't deal with therapy. They deal with medical interventions, and particularly medical interventions for minors. And since
Right.
we,
And Eric, I'm going to interrupt you. Some people are not familiar with the acronym gender affirming care.
yes, thank
So
you.
that's what
I
he's
forgot it
referencing.
myself.
Yeah.
Uh, so in that, and that, so um, it's the worry some people have, and I think they're being overly cautious, is that by even talking about these issues in your therapy, if somebody is undergoing these kinds of medical interventions, that somehow you could get involved as and treated by a DA in a local area as an accessory or as aiding and abetting a person who's following the law. Um, Abortion is another one where a lot of times you'll be working with a minor or even an adult who state prevents, has outlawed abortion. And one of the choices that people have is to leave the state go to a place where you can get an abortion. And I would argue, and I think there is APA policies that affects it, that your job in that situation is to help the client get what they want. So you can consult with them and even advise them, I think, that if they think they want to leave the state and go somewhere, you can discuss that with them. Of course, you would never tell them to do one thing or the other. That was where you would get close to actually being an accessory. And certainly you wouldn't give them the money to go or drive them to where they need to go. But certainly you wouldn't basically avoid talking about it or tell them not to do it necessarily. It really would be trying to figure out how you can help them make their own choice. Um, uh, with regard to gender affirming care, some DA is going to try to take somebody to indict somebody for essentially as an accessory or for aiding and abetting uh, a child. I think it is very unlikely. I mean, there are some times in risk management situations where I say, um, this is you're 100 times more likely to die on your way to the supermarket than you are to get this to happen to you. Well, you're 10,000 times more likely if you're working with someone who is involved in getting gender affirming care for themselves um, to actually have a criminal charge filed against you. But it is something that probably will happen to somebody at some point. One of the things I wanted to do to make sure is I checked with Sheila LeBeau, who's our underwriter at the trust. And if that should happen, the trust would cover your legal expenses, at least to the point where it was decided that you um, had actually committed a criminal act. So you would be defended, and probably that in order for you to be an accessory, you really need some kind of act in furtherance of the actual forbidden um, um, conduct. And so I think that you probably wouldn't have to worry. Um, there's another issue I want to talk about, Amanda, that is documentation. And even in the trust, we've had some discussions. Some might even say there were arguments about how much you should document and whether you shouldn't, for example, if somebody's talking to you about gender affirming care, that you shouldn't mention gender affirming care in your notes, or you should use a euphemism of some kind. I personally think that that's a bad idea. I think what I know is that people who get in trouble often get in trouble because they haven't taken good notes, regardless of what the issue is. So I don't, it's pretty unlikely that saying this client really had was not, had a dyssyntonic relationship with their birth gender, and we're thinking about what they can do about that, and we discussed various options. That's not going to get you in trouble. And saying we discussed various options for it without mentioning what its various options of would be exactly the thing that would get you in trouble if there's a licensing board complaint. So I think good documentation of what you're doing is the best way to protect yourself. Now, some people think you should be careful about saying anything about it. And I'm not saying they're necessarily wrong. I'm just saying that's my experience, that the better the documentation, the better the outcome. That's it.
Great. Thank you, Eric. Julie, anything there very quickly, because I know we're wanting to move to the
I
question.
have so much to say that I don't think we can say it. And I think that's the nature of the beast right now because there is so much nuance and yeah, so I'm just gonna let that lie and see what people are asking because there's no one right answer for any of this. And I think that maybe is ultimately the answer that we have is it depends. So what they teach us in law school. The answer to every question is it depends. And it really does. There are so many different factors to consider.
But the one thing I
Well,
think we would agree about is that when you get into one of these situations, you must consult.
yeah.
Because even if that you can't get at the specific answer, the fact that you reached out to somebody and tried to get as much information as you can shows that you are doing what a reasonable practitioner would do in your situation.
Yeah.
And the more uncertain it is, the better a consultation will protect you.
Yeah, and I do want to add, I mean, Julie's right. There's no one right answer. It's not black and white. Let me say there's very few black and white answers. There are some, but very few. And I also want to say, this is very complex. So you're going to hear us say various things today. Julie and Eric have already said various things that may or may not be on point for a particular case that you have, right? Every single case at this point has to be thought about individually. and the case specific factors have to be considered. And there may be a case where, you know, Eric or all of us would recommend more documentation. There may be a case where we'd recommend less documentation. So we want to be really explicit that there's no black and white answer here. So please don't take one tiny thing you heard in one answer and think, oh, that's the answer that I should do in all my cases, because that would be risky. So I think the biggest take-home message is this is complex. It is nuanced. Tons of consultation right now are really required. Ask, call us, talk to your colleagues. And the last thing I'll add is be very thoughtful. Right now, it is time for us to really think about what we're documenting and why, what we're not documenting and why. So if you have a reasoned, rational reason for that, like for your decision making, that can be helpful. If you're just doing, well, this is what I've done for the last 20 years, so whatever, that may be a problem, right? So just a couple things to add there. Yep, Eric, I'll let you speak.
What I would say is, this is a good time to think about, even if you had, you know, there are something called psychotherapy notes that are particularly as defined by HIPAA, which allows additional ability of the provider not to release the records, and therefore would allow the provider to take more comprehensive notes. Now, that won't protect you if there's a court situation, and I think a lot of people don't bother because you have to have two separate records. But if you think that might be something you'd want to do, you should call the trust and we'll talk to you about how you can do that in a way that protects the confidentiality a little more than just having one unified record.
Yes, I think that's a great recommendation and a great example of how it's nuanced, because as you know, Eric, there are some states where the state laws would mean that psychotherapy notes get turned over anyhow. So again, very good recommendation and call to ask, because the particularities of any clinician and any case may matter, but really good point. Okay, so let's go ahead and turn to the live questions. The first one is from a licensed psychologist in a particular state who says, so they're in one state and they want to offer services through BetterHelp to residents in other states. Are they allowed to do so? Eric, do you want to start with that?
Yes, as I understand it, you're allowed to do so if you are SIPAC, if you're in SIPAC and it's a SIPAC state. There also are some states that aren't in SIPAC but have temporary laws which would allow you to do a certain amount of cross-border stuff. California is one in particular that allows you to provide 30 days of service without being licensed there, and that's quite a lot of that would allow you to do twice a month for the whole year without going over that limit.
Yeah, so I think the main thing is, so long as you are practicing legally in that other state, whether that's legally under SIPAC, under temporary laws, Eric points out, or there are a couple states, Arizona and Florida, who have out-of-state registered telehealth laws. So if you're practicing in that, so long as it's legal practice into the other state.
And that's another reason why you have to know the laws.
Right,
Yeah.
Exactly.
And I would say don't depend on BetterHelp to give you appropriate referrals. It's your job to know where that client is and to know the laws and whether there is a way for you to practice. And those temporary practice provisions, a lot of them are short. You get 5 days, you get 10 days a year. And so don't rely on that as something you can use for ongoing therapy. California's is pretty generous. Colorado has a 20-day per year allowance. But if it's someplace that allows you to do it 5 days a year, don't start with a new client assuming that you're going to be finished with them in 5 days. So it is incumbent on you. Do not trust these referral sources to do that work for you. They're not looking out for your license. Make sure you know where those clients are and whether there's a way for you to practice legally into those locations.
And when in doubt, you'll get better help by calling the trust.
Oh, that was good.
That's right. Consult. And again, think about those case specifics. And just quickly, I'll mention when you're thinking about cross-jurisdictional telehealth, it's not just regulatory issues. Yes, you got to think about regulatory issues, but then you have a whole host of other, clinical suitability, emergency planning, service reimbursement, regional differences, cultural differences, et cetera. So lots to think about on a case-by-case basis. Julie, I'm going to send this one to you because I think it came out of something you said early on when you were talking about the answer to that first question. But the question here is, are you saying that the ethics code takes precedence over the law or board regulations? And I think it's great that you can explain.
Good question. Yeah. So
Great.
in some states, the ethics code is law. Okay, so you should know if your law has, or if your state has actually incorporated the ethics code into statute, that will be, you will know that. And then in those places, the ethics code has the power of the law. But in other places, it is more of an implied relationship. So in Colorado, we have not actually said the APA ethics code is statute. We have said that you are required by statute to meet the generally accepted standards of the profession, and those are defined by professional associations. So by implication, you do need to follow the ethics code. But yeah, the ethics code does not necessarily supersede law from a legal standpoint. And that's why there is the section in the ethics code about conflicts between the ethics code and the law. My point with that was when there are so many things that are changing, and when laws and regulations are changing every day, the ethics code at least is a consistent thing we can look to provide some level of guidance if we are just honestly not sure what to do, or if the law dictates that we do something that we believe is unethical, that is clearly unethical under the ethics code. That's where we have to make our own decisions about what risk we're willing to take. And there may be situations where you decide that your ethical obligation is more important than following the letter of the law. And if you make that choice, just understand that that's the choice you're making, and that you will need to be able to justify that. You'll need to be able to point to the sections of the ethics code that say what you're doing is the right thing. And there will be different people will have different outcomes when it comes to that. But to me, that's sort of the North Star for me. Right now, the ethics code is a main source of guidance. The laws are vital. If there's a clear conflict between the two, then you're either going to break the ethics code or you're going to break the law, and you've got to decide which one you want to do. Those are my least favorite consultation calls, and I know you've all had them. It's like, okay, you're either going to break what your law says or you're going to bust through the ethics code, and we need to figure out which one you're comfortable with and which board complaint you would want to defend. It's a horrible thing to have to say, but that's what it comes down to sometimes. So there's never, you can't always say, yes, the ethics code wins. But it is our guiding principle, and we should at least always consider it, even if it's not precisely what we follow.
So let me give you a for instance that I think will help to clarify this. Let's say you are working with somebody, a child, whose parents are involved in a divorce, and there's likely to be a nasty custody battle. And you get a subpoena. In that situation, probably given the state law, you have to at least respond to the subpoena. But you can take action to try to prevent the subpoena from actually compelling you to turn over the information. You can file a motion to quash. You can work with the person who you're working with to make sure they understand how their options may allow them not to have that information released. You can ask the court to put the record under seal. Those are all ways that you can work to keep the ethics code as the primary issue when you're in that situation. But the first rule of risk management is don't ever argue with a judge. So if the judge gives you a court order to turn the information over, at that point, you go with the law.
Right. No, I think you both make good points. And if someone is going to take the stance that that it's their view that they're going to do the quote unquote ethical thing and follow the code, and that be in violation of a law, well, people are able to choose that. But just because you have an ethical rationale does not mean you will avoid legal consequences. If you break the law, there may end up being legal consequences, whether you have an ethical rationale or not. So this is where it is complex. It requires, again, case by case thoughtfulness about the factors and your personal risk level. Like Julie said, you as the clinician, your personal risk level. And we definitely recommend consulting a lot in these cases. So hopefully that's a very Unclear answer, but that's the best response. Well, hopefully it's clear. It's just there's lots of nuances. So, all right, another question. This is a clinician who is licensed in Massachusetts, but now is spending most retirement time in California. And they want to know if they can practice in California, even though they are not licensed. So they live in Massachusetts. I presume they're licensed in yeah, they have a license in Mass. They're in California a lot. Can they practice in California without a license? Eric, do you want to take that?
They can if they're working with clients in Massachusetts, but they can't work with clients in California because that would be practicing without a license, which is a criminal offense. So to the extent that they can get within the temporary practice law in California, they can do that. But if you're going to move to California, even if you get a license if you can, because if you get a complaint and you don't have a license, it's going to be hard to defend yourself.
Right, thank you. Julie, anything you wanted to add there?
I think that's generally how most states operate, that they expect you to be licensed where the client is, not necessarily where your body is, but I cannot say definitively that is how all 50 states operate. I would say any state that tries to assert that you must be licensed, like if California says you need to be licensed in California in order to work with people in another state, I think they're overstepping their authority. And I think it would be hard to justify that from a legal standpoint. It also would not shock me to learn that there might be a state or two that tries to assert that level of control. And so that's a situation where you want to make sure that you consult and take a look at that state law and confirm it. And a lot of times, a lot of telehealth questions like that, you can actually find the answer to on FAQs on the board webpage. That's another little Julie hack. And not only look for policies and specific statements, but FAQs almost always these days will include something about I'm licensed in another state, or I want to practice into your state. So take a look at those FAQs also and see if you can get some primary source information on the laws in that state.
Great, thank you. Okay, there's a question here. There's actually two I'm going to combine. Someone asked, what is mandatory disclosures? And then a link up with that was, Julie, you mentioned a specific disclosure in Colorado that there's some confusion about. But if you can just explain, I think Eric is the one who called a mandatory disclosure. So just explain what we mean about that, because that's the law that you do need to know, mandatory disclosures in general. And then Julie, I'll let you start, and Eric, you can come in second just to also explain Colorado.
Yeah. When I speak about the mandatory disclosure statement, that is a specific statute in Colorado that you are required to disclose to every client that you see. And I do know that other states, I don't know how many, but I have heard, and I can't say off the top of my head, sorry, but there's at least one other state I've heard of that has some level of, here is a statement you must give to all of your clients. And so when I talk about mandatory disclosures, that is a specific term that refers to the mandatory disclosure statement that the state of Colorado requires that you provide to your statement. So it's just, or to your clients. So it's basically saying you must give every client this piece of information before you see them. And it says specifically in statute, it has to be signed no later than the second session. So that's really just referring to any kind of law in a state that would require that you disclose X information to all of your clients. That's
Yes.
what I mean.
Yes, and I think, and Eric, correct me if I'm wrong, when you were talking about mandated disclosures in what you said in terms of child abuse, elder and handicapped person abuse.
Yes.
So you need to, when you're practicing in another state, you need to know what are the mandated disclosures in that state law. Is that correct, Eric? What you were saying?
And I should clarify, that's only if you are practicing in SIPAC. If you're practicing in the state you're licensed in, but the abuse takes place in another state, you're not required to report. In fact, we recommend against it because you would lose your immunity. But if you are SIPAC, you are bound by the laws in the state where the client resides.
Yes. Yes. So notice the differences there. There are key differences because one is regulated under SIPAC and one is not. So if you have questions about where to report, again, any mandatory, that's when please consult. Okay, another question here, and I know we get a lot of calls on this. The person says very recently they're getting a lot of insurance company audit requests. They're requesting the complete clinical record for the prior year, including all progress notes. The clinician's uncomfortable with releasing them, but should they send the progress notes or not? What are the options? And Julie, do you want to start?
Such a good question. And I do think it's really important to distinguish different types of audits. There is a thing called a risk adjustment audit that is a creature of the Affordable Care Act. It is a data gathering requirement. It is not a targeted audit trying to claw back money. It is not you having to prove the medical necessity of the services. It is data that they are required to gather. And I know that at first, when these first started coming out, they would ask for the full record for the risk adjustment audit. And the APA did some advocacy and essentially said, look, HIPAA's got this minimum necessary rule. We are only supposed to disclose what is necessary for you to accomplish your purpose. So what do you actually need in order to gather this data? And so a lot of the companies, initially you would have to sort of push back and say, I'm not sending you the whole record. I'm sending you this summary with this information per the minimum necessary rule. I actually saw today, I was so happy to see one of these email requests for a risk adjustment audit that actually said, you don't have to send the full record. And they gave the list of the summarized information to send. And so depending on the type of audit, you may need to send the full record. If you're in network with an insurance company and they're auditing you for the medical necessity and appropriateness of the service you've provided, listen, we all agree when we sign up for health insurance that we will let the health insurance company have access to our information. HIPAA has an exception for payment and for healthcare operations. And we should all ideally have something in our informed consent that reminds patients and clients that there may be requests for your record by the insurance company, and by asking me to, provide you with these in-network services, I'm going to have to comply with those requests. And so we don't always have the ability to say no. If a client says, no, I do not want you to send that information, you need to let them know that that could lead to consequences for their insurance, because they're probably breaching their agreement with their insurance company. We can't expect insurance companies to pay for services without giving them the evidence that those services are happening and that they're necessary. So if it's a risk adjustment audit, less is more. If you're not sure, ask. Send an email, a call, and say, what is the minimum information that you need? What is the minimum necessary information under HIPAA that I must send to you? You can always disclose not enough and be wrong, and they'll ask you for more, I promise. But if you disclose more, you can't undo it. And so being cautious is fine. I will say that sometimes I hear people who are just adamant, I will never release my record to anybody. It is my record. Well, no, it's not. And I know a lot of us were trained that way back when. It's not your record. You're keeping a record of the services you provided on behalf of your patient. They can have it. The insurance companies can have it. They can allow it. They can ask you to disclose it. They can publish it in the newspaper if they want to. So just remember, when you're documenting, you do need to think about that audience, and you need to think about the fact that insurance companies may be looking at that, clients may be looking at that, and most importantly, from our standpoint, your licensing boards may be looking at that. So document with that in mind.
I do want to say that you don't need permission in most states to turn that over.
Mhm.
You don't have to deal with it with a client. And also, in the 35 years I've been doing it, I've never heard of a situation where an insurance company, which demanded the whole record, has ever leaked anything outside of its borders. So you don't have to worry somehow that this will be a major. It's not like the insurance company will say, it's not like when you do something, when you're tracking your Google things. Insurance companies, if they released any information, they would have a tremendous legal liability.
Right, right. Thank you both. Eric, I'm going to send this one to you, and I'm going to try to get in. We're down to about 9 minutes, so I'm going to try to fit in as many as we can here. What are the ethical obligations for keeping a small therapy dog in the consulting room? Eric?
I would say that you would have to have informed consent for sure. And you should, if you, I would not put, if I wouldn't try to do that in the middle of a therapy, because you put the client then in a very bad position of either having to say, no, I don't want the dog there, which then could cause a somewhat of a breach in your relationship with the therapist, or with the client. Um, the other thing you need to make sure is your dog is very well trained. Um, uh, if you have a therapy dog and the therapy dog bites one of your clients, that's going to be a major lawsuit against you. Um, so having, just because you have a pet and you want the pet to be with you, that is not a sufficient amount. That's not a therapy dog.
Mhm.
That's an emotional support animal for you.
Yes. And Eric, because I agree, and there are certifications and specific trainings for therapy dogs.
Mhm.
There's also specific insurance you can get for therapy dogs. So it's a whole thing. And the piece I always add in here too is remember that your dog is a dog, right? Even a therapy dog is a dog. Like Eric says, they might bite. They too can get stressed and overwhelmed. So there's a lot of things to think about in doing that. But hopefully we touched on a little bit of that. And I would add that's where you can consult too. If you have a specific case, give us a call. Because the other thing you may need to think about is, do any of your clients have allergies? How would that be handled if the next person who comes in the room has a serious allergy to dogs, those kinds of things. So there's a lot to think through. Julie, anything you want to add before we move on?
You just hit on the two things I was thinking about. Allergy, you have to be able to accommodate people who won't be able to come into your office because there's an animal there. Yeah.
Right. Okay, great. So someone here says it's challenging to care for patients when we are all going through the same stress, just like the early days of COVID. How do we balance acknowledging the state of the country with helping folks pivot to talking about their original presenting concerns? Julie, why don't you start us?
That's such a good question. It makes me think about 9/11. It makes me think about COVID. I mean, there's now been 3 situations in my professional life where I'm going through the same trauma that my clients are going through. And I think there's a balance that we need to strike. Obviously, we need to be human to some extent. And it's certainly, for us to act as if that we have no impact, that this isn't affecting us in any way, that's not going to be helpful to our clients. So this whole complete blank slate and objectivity maybe doesn't nurture the relationship. But at the same time, the therapy can't be about us. The therapy has to be about our clients. So we always need to be patient-centered and, validating someone's experience, a little bit of self-disclosure for a clinical purpose to just let someone feel like you understand a little bit about where they're coming from. That's appropriate if it is for a clinical purpose and it is limited. I think we have to be real and we have to be genuine in our relationships with our clients. And that's going to include, sometimes it's just as easy as saying, yeah, I struggle with that too. But then you got to refocus it on what your patient needs and get it back to what your clinical goals are. Now, sometimes someone comes in for something and it's no longer relevant. There's so many other things going on. So it's not always like we must adhere to the original treatment plan that we developed last year, right? It's dynamic. And so if these new stressors have now changed the focus of treatment, that's okay. We don't have to force it to go, oh no, but you came in here with social anxiety. We have to talk about that. Well, no, meet our clients where they are, acknowledge the humanity that we're all going through a thing, but retain the focus on them. And this might be a really good time for us to have our own therapist if we don't already, right? Because we do need a place to process what that's like, but it's not in our therapy offices. It's in someone else's if that's what we need.
Times like this, there's a real danger of countertransference. And I know it's hard to not want to discuss with your clients what's going on, particularly if they bring it up. But it's more what they think and what they need than, oh, well, yes, what I saw in Rachel last night was.
Right. And it underscores, you both make really great points. And I think it underscores the need for self-care, right? Just like during COVID, we actually had to take more of an effort to increase our self-care because that is what allows us to stay steady in those difficult moments, right? Whether we're sitting with a client who has similar political views as we do or has different political views, we do have to maintain our centeredness and stability and boundaries. And a lot of that's going to be dependent on us taking good care of ourselves. So, and the other piece I'll just add there, and I'm going to try to fit in one more question at least, but I think this is a time too for us to look out for each other, right? To that sort of idea of communal care. So if you have colleagues and, reach out, if you think they're struggling, get together, talk about the struggles. That can help us keep it out of our therapy room and in our own, in the places like Julie said, where it does belong. So those are, we get through the tough times together is kind of my point.
One more thing about that, can I?
Please.
Is you also have to watch out to not get involved with your colleagues. Your colleagues may have strong disagreements with you politically,
Right.
and it's a bad idea to try to have a long conversation about that, and to risk having a breach in your professional relationship with a colleague.
Yeah, I think now's the time to really remember that reasonable minds can differ. There's lots of different opinions in the world, right? We're not here to say one opinion is right and one opinion is wrong for the most part, right? So trying to, using all the skills that we can to try to understand and take care of ourselves.